Gestational trophoblastic disease, competency code OG 34.3. Specific learning objectives of gestational trophoblastic diseases are to define gestational trophoblastic disease, to discuss risk factors, clinical features and staging, to discuss complications and differential diagnosis, to describe the diagnosis and management of molar pregnancy and GTDs. Gestational trophoblastic diseases defined as these are group of interrelated diseases of the abnormal proliferation of placental trophoblastic tissue. GTDs are classified into complete molar pregnancy, partial molar pregnancy, invasive mole, choriocarcinoma, placental site trophoblastic tumor, epithelioid trophoblastic tumor. Incidence of hydatidiform mole. It is uncommon complication of pregnancy. An average consultant obstetrician may deal with only one new case of GTD every second year. Its incidence in US, it is 1 in 1000, but in India 2.4 per 1000. It is more common in Asia. Hydatidiform mole, it is a disease of chorionic villi characterized by proliferation and hydropic degeneration of chorionic villi. These are two types, that is complete mole and partial mole. In this complete mole, there is a duplication of the paternal chromosomes. But in case of partial mole, it is a triploidy. Here genetic complete mole, theca lutein cyst, we can see in 10 to 25% of the cases, and it is more prone to develop choriocarcinoma. Partial mole, parts of the fetus, we can see that a genetic karyotyping is 69XXY or 69XYY. In this, there is involvement of the paternal and maternal chromosomes, but in complete mole only paternal androgenesis is there. So this is about the contribution of paternal and maternal chromosomes involvement in complete mole and partial mole. Risk factors. Risk factors are vitamin A deficiency, folic acid deficiency, blood group A, low socioeconomic status, Asian race, obstetric history, previous abortion, previous molar pregnancy. These are risk factors. Clinical features are amenorrhea, exaggerated symptoms of pregnancy and bleeding in early pregnancy, pain in lower abdomen, serosanguinous discharge, abdominal enlargement more than expected date of gestational age, and absence of fetal movements, and passage of vesicles is a pathognomic of molar pregnancy. And if again they have the complications of anemia, preeclampsia, hyperemesis gravidarum. So they can have symptoms of anemia, hyperemesis gravidarum, preeclampsia, hyperthyroidism, and partial mole is less symptomatic than the complete mole and usually discovered accidentally. And the clinical features of complete mole are variable bleeding is present vaginally, there is a bleeding and uterine size is larger than the dates, and theca lutein cysts are 10 to 25%, medical complications are 6 to 20%, post-molar gestational trophoblastic neoplasia we can see in 7 to 30%. But in case of partial mole, vaginal bleeding we can see in partial mole also, uterine size is smaller than the dates, theca lutein cyst, it's rare in partial mole, medical complications also rare, and postmolar gestational trophoblastic neoplasia we can see in 2.5 to 7.5% of the cases. On pathology, evidence of fetus is absent in complete molar pregnancy, but it is maybe there in partial mole. And villus edema is present in complete mole, and trophoblastic proliferation is diffuse in complete mole and focal in partial mole. And immunostaining for P57KIP2, it is negative in complete mole and positive in partial mole. Karyotyping is 46XX in complete mole and 69XXX or 69XXY, 69XYY in case of partial mole. So, origin of chromosomes is from paternal in case of complete mole, maternal and paternal involvement is there in partial mole. So, this is about differentiating factors about complete mole and partial mole. So, we can see here there is a grape-like vesicles, pearly white grape-like vesicles we can see. Signs uterus is larger than the dates and doughy in consistency we can see. And in partial mole, uterus is small for dates and thecal uterine cyst we can see 25-30% in complete mole. Now, but they are rare in partial mole. Differential diagnosis of molar pregnancy, that is mistaken dates, threatened abortion, multiple pregnancy, acute hydramnios, fibroid in pregnancy. Complications are hemorrhage, anemia, infection, thyroid storm seen in 3% of the cases, embolization with acute pulmonary insufficiency and coagulation profile, abnormalities, uterine perforation, delayed recurrent mole and choriocarcinoma. Diagnosis done by history, clinical examination, investigations like complete blood count, clotting function test, renal and liver function test, blood grouping and typing, and HCG level, and chest X-ray, ultrasonography. So, tumor markers are all produce human chorionic gonadotropin. This beta HCG, it is an ideal marker used for diagnosis, prognosis and follow-up. HPL is ideal for placental site trophoblastic tumors. Management is after appropriate and relevant investigations, we need to treat with suction evacuation. This is the ideal method. Before planning for suction evacuation, we need to keep packed cells, keep it ready under local anesthesia or under short general anesthesia we can do. We need to keep large bore IV access and cervix must be dilated. Oxytocin infusion need to be started. Evacuation with suction cannula we need to do, and gentle uterine curettage at the end of the procedure we need to do for the completion of the procedure. After evacuation of the mole, Rh negative patients should be treated with anti-D immunoglobulins. After the evacuation, even the fetal RBCs should not be present in the complete mole, but we need to give Rh negative patients anti-D. Post-evacuation quantitative HCG level after 48 hours we need to do. Later every week until normal level we have to do. Usually within 3 weeks, it is for 3 weeks. 3 monthly for 6 months. During follow-up period, pelvic examination, ultrasonography if it is necessary, we have to do. And throughout this follow-up period, we need to suggest patient contraception. Contraception for 1 year, it is essential. And Combined oral contraceptive pills we can advise, and progesterone only pills also safe during this period. Barrier methods, their failure rate is very high, so it is better to combine with progesterone only pills or combined oral contraceptive pills in case of barrier methods. Persistent GTD, high static or rising HCG level after 1 or 2 uterine evacuations on days 1, 7, 14 and 21, 4 values. Persistence of HCG beyond 6 months and persistent uterine hemorrhage with raised HCG levels, evidence of metastasis, histological diagnosis of choriocarcinoma or placental site trophoblastic tumor. In this persistent GTD, high level of HCG after 1 or 2 uterine evacuations, persistence of HCG beyond 6 months, uterine hemorrhage persistence, histological diagnosis of choriocarcinoma and placental site trophoblastic tumor, we need to treat with chemotherapy. Choriocarcinoma, it occurs in approximately 1 case every 20,000 to 40,000 pregnancies. Invasive mole, it is locally invasive and it will perforate into the myometrium and serosal layer. Invasive mole, it is most common gestational trophoblastic neoplasia and it is locally invasive, but metastasis in 5% of the cases. Invasive mole always develops after complete or partial mole. And pathology showing hydrophilic villi and proliferation of cytotrophoblast and syncytiotrophoblast. They invade the myometrium and serosa. So invasive mole also we need to treat it because it is locally malignant. Placental site trophoblastic tumor consists of predominantly intermediate trophoblast at the placental site. There is no villi. It can follow any form of pregnancy but develop more commonly following normal pregnancy. It produces low levels of HCG relative to their mass and their marker is HPL. Infiltrate only within the uterus. And hysterectomy is the primary method of treatment for non-metastatic disease. It is relatively insensitive to chemotherapy. Metastatic disease has a poor prognosis and is treated by aggressive combination of chemotherapy, that is MRP. It has a distinctive renal glomerular lesion causing proteinuria and hematuria. Spontaneous uterine perforation may occur and it may also follow molar pregnancy. Epithelioid trophoblastic tumor. It is rare, extravillous intermediate trophoblastic tumor. It is distinct from choriocarcinoma, invasive mole and placental site trophoblastic tumor. The preceding pregnancy may be remote or even unidentified. Microscopically, it resembles placental site trophoblastic tumor, but cells are smaller with less nuclear pleomorphism. Grossly, the tumor grows in a nodular fashion rather than infiltrative pattern. Hysterectomy is the primary method of treatment. But regarding epithelioid trophoblastic tumor, only few reports are there. So, placental site trophoblastic tumor, epithelioid trophoblastic tumor, primary treatment is hysterectomy. Phygostaging of gestational trophoblastic tumor. Stage 1, disease is confined to the uterus. In stage 2, gestational trophoblastic disease extends outside the uterus but limited to the genital structures. Stage 3. Gestational trophoblastic neoplasia extends to the lungs with or without known genital tract involvement. Stage 4. All other metastatic sites, that is brain and liver. Modified WHO prognostic scoring system. In this, scores are given 0, 1 to 4 and factors considering for this classification scoring system: age, antecedent pregnancy, interval months from index pregnancy, pre-treatment serum HCG, largest tumor size, site of metastasis, number of metastasis, previous failed chemotherapy. Age less than 40, 0 scoring system, more than 40, 1 scoring system, antecedent pregnancy, molar pregnancy 0, abortion, following term pregnancy risk is more, that is following abortion risk scoring it is 1, 2 following term. Interval months from index pregnancy less than 4 months 0, 4 to 6 months 1, 7 to 12 months 2, more than 13 months 4 scoring. Pre-treatment HCG level less than 10 to the power of 3, 0, 10 to the power of 3 to 10 to the power of 4, 1, 10 to the power of 4 to 10 to the power of 5, 2, 10 to the power of 5, 4. Largest tumor size 3 to 5 centimeters 1, more than 5 centimeters 2. Site of metastasis lung is 0 scoring system, spleen kidney 1, GIT 2, liver and brain it is 4. Number of metastasis 1 to 4 scoring 1, 5 to 8 scoring 2, more than 8 score 4. Previous failed chemotherapy with 1 drug 2 scoring system, more than 2 failed chemotherapy 4. So total scoring, if it is less than 6, that is low risk. If total scoring more than 7, that is high risk. So for low risk patients, we need to treat with methotrexate with a low dose or actinomycin D IV cyclical. We can treat these conditions. Methotrexate, it is a drug of choice and for low risk group, and it is effective and well tolerated by the patient. It is most commonly used for treatment of GTN. It is a folic acid antagonist, inhibits DNA and RNA synthesis, inhibits rapidly dividing cells. Main side effects with methotrexate are gastrointestinal mucositis, diarrhea, stomatitis, nausea, alopecia, bone marrow suppression and hepatotoxicity. With actinomycin D, it is also as effective as methotrexate. It is used for treatment of low risk group of gestational trophoblastic neoplasia. Main adverse effects are alopecia, nausea and nephrotoxicity. With actinomycin D, nephrotoxicity. With methotrexate, bone marrow suppression and hepatotoxicity. These are the main side effects with these drugs. For high risk groups, we are suggesting etoposide, methotrexate, actinomycin D, cyclophosphamide, vincristine. This Amaco regimen, cyclically or alternatingly we are using. Methotrexate and etoposide, actinomycin EMA regimen also we are using for high risk group. Indications for hysterectomy in the management of gestational trophoblastic disease. Older patients with complete family size, it is a locally malignant disease, that is locally invasive, excessive uncontrollable bleeding before or during the curettage, suction evacuation, chemo-resistant localized uterine tumor, placental site trophoblastic tumor. These are the indications for hysterectomy. So here we have discussed what are the specific learning objectives. Definition of gestational trophoblastic disease, that is abnormal proliferation of the placental chorionic villus tissue, that is cytotrophoblast, syncytial trophoblast. What is complete mole? What is partial mole? And what are the differentiating factors? And what are the differential diagnostic conditions, that is mistaken dates, along with other gynecological problems like fibroid and clinical features. Clinical features, that is nausea, vomiting because of high level of HCG, there is a hyperemesis gravidarum, and there is a clinical features of anemia, preeclampsia, and thyroid storm we can see. In this we can see thecal luteal cyst also, but they are asymptomatic. There is no need of treatment for thecal luteal cyst even though they are more than 6 centimeters. And main treatment of choice is suction evacuation. After suction evacuation, follow-up of the patient, it is a crucial period, about 1 year. During this period, strict contraception should be advised. Barrier method, its failure rate is very high, so we need to suggest combined oral contraceptive pills or progesterone only pills or progesterone injections. During the follow-up, after suction evacuation, 48 hours later, beta HCG need to be measured. After that, weekly we need to measure. Within 6 to 8 weeks, beta HCG comes to normal, that is less than 5 international units per ml. But beta HCG level estimation should be done monthly until 6 months. During the follow-up period, pelvic examination must and should. Check for any bleeding, any nodularity, any metastatic conditions, we have to check it. And also, if the patient is symptomatic, chest x-ray and ultrasonography, abdomen and pelvis also need to be suggested. This is about molar pregnancy. But in case of choriocarcinoma, we have to start treatment with chemotherapy, and if there is any high risk gestational trophoblastic neoplasia, we need to treat it with a multi-agent chemotherapy, EMACO every 2 weeks, monitor serum HCG weekly, monitor response, decline to undetectable over 3 weeks or not, or in case of resistance, the increase or plateau level of the HCG we can see even after 2 weeks. In such conditions, switch to alternative regimen if it is resistant. Monthly HCG till 12 consecutive non-detectable levels we have to do. High risk groups we need to suggest 2 years of contraception. But in case of molar pregnancy, 1 year it is sufficient. Management of chemo-resistant metastasis, surgery, radiation, selective arterial embolization, high-dose methotrexate we need to suggest. Gestational trophoblastic neoplasia has a good prognosis with 100% complete remission rates in low-risk groups. With multi-agent therapy, survival rate in high-risk groups, it is about 80 to 90%. When brain metastasis is present, survival reduced to 50 to 60%. And pregnancy after gestational trophoblastic disease, contraception should be advised for all women with molar pregnancy and gestational trophoblastic disease. There is a 1 to 2% risk of repeat molar pregnancy after complete or partial mole. Therefore, ultrasonography should be performed during first trimester itself. Outcome of pregnancies after chemotherapy for GTN has been found to be normal. And the term gestational trophoblastic disease used to describe group of tumors. So here we are discussing about that molar pregnancy, that is complete or partial molar pregnancy, placental site, epithelioid, locally invasive, that is invasive mole, and choriocarcinoma. These are all come under gestational trophoblastic disease, and we summarized all these in this competency code. And gestational trophoblastic neoplasia evaluation also we have discussed here, and that evaluation includes history, clinical examination, beta HCG and imaging techniques, and staging and prognostic scoring also we have discussed in this chapter. In a low risk disease, that is less than 6, high risk, that is scoring more than 7. In low risk disease, engage not completed family, single agent chemotherapy, follow up for 1 year, contraception must and should for 1 year. In case of persistent trophoblastic disease or placental site trophoblastic disease, completed family, hysterectomy is the treatment of choice. Follow up for 1 year is essential. In case of high risk disease, multi-agent chemotherapy, follow up for 2 years, contraception for 2 years is essential. This is about gestational trophoblastic disease. We have covered all learning objectives in this chapter. Thank you.